The project is titled Examining Spatial Patterns and Predictors of Liver Cancer Among Hispanic Americans in California. So why is this important? Liver cancer is one of the fastest growing cancers in the United States, with a 2.6% growth every year over the last 10 years. This is at the same time when we see liver cancer decreasing in most parts of Asia, but see it increasing in Europe and North America. Hispanic Americans had the greatest increase in liver cancer incidence from 1992 to 2002, with a 31% increase among men and a 63% increase among women. And to give you some absolute numbers, we should be seeing about 5,100 new cases of liver cancer among Hispanic Americans this year, and 3,300 deaths from liver cancer. There is currently no general population screening test, and the five-year survival rate is quite low. It's about 18%. There is limited understanding of both the spatial distribution of liver cancer and the underlying risk factors for different groups. So the research is warranted regardless of the growth in the incidence rate. Interdisciplinary research is necessary to understand how social, cultural, clinical, environmental, and biological factors cause liver cancer and contribute to health disparities. So here's a picture of a liver. I just wanted to show you that the liver is essentially responsible for the breakdown and storage of nutrients. It secretes bile into your intestines to break down alcohol, drugs, other toxic products, and it also creates clotting factors. So it's very important that it functions properly. On the right is a very simple diagram of the stages of liver cancer. So on the top, we see there's a healthy liver here. And then essentially what happens once the liver starts becoming unhealthy is that there's fibrosis, which means that there's scarring around the liver or on the liver. When almost the totality of the liver is scarred, it's considered cirrhosis. So essentially what's happening is the liver keeps getting damaged and it keeps trying to fix itself, and in the process it's getting scarred. So these cells are obtaining damage throughout this process, and then eventually turns into hepatocellular carcinoma. So this is a subset of liver cancer, but it is the most common type. It attributes for about 75% of liver cancer in the United States. So here I wanted to show the main risk factors for liver cancer. So hepatitis B and C are primary risk factors. Hepatitis B is vaccine preventable, and hepatitis C, there's no vaccine. But the way that public health prevention efforts tackle this is both through screening of blood and also through needle and syringe exchange programs within the community. Hepatitis D is listed here, but it's a co-occurring infection with B, so it's not a primary risk factor. The risk factors on the right are more common and can be have a greater attributable proportion in developed countries. In developing countries, Hep B and C are very common because the public health prevention efforts just aren't there. But in the United States, things such as being male, you're at increased risk, being obese, having diabetes, being either Asian or Pacific Islander or Hispanic, and then being a binge drinker. A couple others that I didn't put on here. Smoking is a risk factor, as well as being born from 1945 to 1965, and that's because the prevalence of hepatitis C among those who were born during that time is very high, and now they're aging to the point where we're seeing liver cancer among those individuals. Another thing is that we're kind of seeing those individuals who have had cirrhosis, the medical care is getting better, so now that, as you saw in the pathway, since those people are surviving longer, they're also more likely to get liver cancer. Here's the age-adjusted incidence rates of liver and intrahepatic bile duct cancer from 2008 to 2012. So I just wanted to show you that California, you can see, is in the highest group compared to the rest of the country. So there warrants some research in California. And then here I wanted to show you the comparison for different races. Again, this is the age-specific liver and intrahepatic bile duct cancer incidence rates by race or ethnicity and age and year of diagnosis. So Asian and Pacific Islander tend to be high anyways, but if we compare Hispanic to white, we can see that the rates are quite high. We can also see that those who are diagnosed more recently, so this dotted blue line, it's 2008 to 2012, among all ages, they do have a higher incidence rate. So for my project, I'm using spatial data to map the liver cancer cases to get some insight into the variation of disease burden throughout California. Within small areas, the association of multi-level risk factors with liver cancer outcomes can be used to understand the mechanisms of disease occurrence. There is great potential to develop culturally appropriate public health prevention efforts targeted at a tailored set of risk factors within clusters of liver cancer cases. My primary objective was to understand how geography contributes to the burden of and risk factors for liver cancers among Hispanic Americans in California. So first, I identified the spatial clusters of liver cancer among Hispanic Americans in California using a hotspot analysis, and then I plan to identify the relative contribution of known risk factors in regions with higher disease burden using spatial modeling techniques. So my data was obtained from the California Cancer Registry, so we have all the liver cancer cases from 2000 to 2015. So I did just get my data like 2 weeks ago, so I tried to do as much as I can before this presentation. The rates for each medical study service area were age-adjusted using direct standardization. We used the 2010 US Census 5-year age groups as the standard population. So I'll highlight the things I learned throughout because I definitely forgot to include the slide for that. So one cool thing was I learned how to do the directly standardized rates in SAS, which is good because we've only done small examples by hand when we learn. And then for the geospatial analysis, I did a spatial autocorrelation and local index of spatial autocorrelation. I also did a hotspot analysis, and the outcome was the age-adjusted liver cancer incidence rates from 2000 to 2015 to describe those spatial patterns. And again, they were run in SAS 9.4 and ArcMap 10.6. And to give you context for MSSA, for those who are not familiar, a census tract is smaller than an MSSA and a county is larger than an MSSA, so it's in the middle. So our comparison groups were Asian and white. So we do see similar rates of by sex across the different groups, but I do want to point out again that the male to female disparity is quite high, more than you tend to see for other cancers. For the age, we see that the largest proportion of those who are 45 to 54 is among Hispanics. The largest proportion of those who are 65 to 84 is among Asian. And then the largest proportion of those who are 55 to 64 is among white individuals. Here we see that Hispanic individuals and white individuals tend to be more are single and never married versus Asians who are primarily married. For the stage, we also didn't see any large differential across different racial groups, but I did want to point out that we do see a pretty large proportion that are regional by direct extension and regional and remote. So that's about 15 to 16%, and that's because, again, there's no screening for this disease, so often it's caught at a very advanced stage. So here I mapped for Hispanics the standard rate and the standard error for the adjusted liver cancer incidence rates. So the median number of cases was 13. The 25th percentile was 8 cases, and the 75th was 21 cases. We do see, so all of these white areas, there were no cases, which seems unreasonable, but then when you explore further, we know that these are either rural or frontier areas in California. So these MSSAs have less than 250 persons per square mile. Sometimes they have less than 11 persons per square mile, so often there's a lot of like desert type areas in California where people just aren't there. So we do see some high rates in these red areas right here. And this, to orient you a little bit, for those who are unfamiliar, this is San Francisco. This, I think right here is LA, and this is San Diego. So we see high rates here too. On the left, I also plotted the standard errors, so you can see the uncertainty in some of the estimates. This is because we use directly standardized rates, so some of these places had very few cases, less than 10 over 15 years, so the errors are going to be very high. Here I wanted to show you the rates on the right are the same, but I wanted to contrast it against the proportion of Hispanics within each MSSA. So the yellow and the red is where we see a high amount of Hispanic population, and it does overlay with some of the high rates. So once we do a model where we include all the cases, we would probably want to control for the proportion of Hispanics. This one is, but I plan to go back and do this for Asian, white, and then all cases, so, which I didn't get to do yet. So the next slide, let's see. So here's the spatial autocorrelation among Hispanics. So what does that mean? So the question we'll be answering is, do spaces near each other have similar or different rates? So on the left is the global Moran's I. This is the global spatial autocorrelation test statistic right here. And the range can be from -1 to 1. We see that it's quite low, it's less than 0.1. Although it's significant, it has a very weak magnitude. So that's telling us that there isn't really a spatial component to what's going on here. And on the right, I have the local indicators of spatial autocorrelation. This is also an exploratory map or technique, and it may help to identify regions of a map where neighboring areas are unusually alike or different. So we see here that the light pink is where there's high clusters of cases surrounded by other MSSAs with high cases surrounded by other MSSAs with high cases. And then the opposite is true here. So we see MSSAs with low numbers of cases surrounded by other MSSAs with low numbers of cases. So around LA, San Diego, and San Francisco, we do see some here. And then these are outliers. So these bright red spots are where the cases are unusually high compared to their neighbors, and vice versa for the dark blue spots. So then we ran a hotspot analysis. So although the spatial autocorrelation was not strong, the magnitude was not high, it was still warranted because it was about 0.07, so there's something going on. So this tool allows us to look at each MSSA in the context of its neighbors. A statistically significant hotspot means an MSSA will have a high value and be surrounded by other MSSAs with high values. So we see 4 hotspots here, and we can see 1 cold spot here, which is the opposite. So you're seeing low rates, surrounded by other low rates. So again, I wanted to mention that I plan to do this again for whites, Asians, Pacific Islander, and all individuals, so that way we do have a comparison group. And the next step is to use an ordinary least squares regression model to assess the global relationship between predictors and liver cancer incidence. So this is just using a traditional regression model in which you assume the spatial dimension to be random, and that way there's no reason to actually use a geographic weighted regression. So this is what people do normally anyways. So this is, when you do the ordinary least squares regression, this is the point in which you test your model. So you look for things like collinearity, or if you have too many variables, things like that. And then I want to evaluate the potential for a spatial model. So as I showed you earlier, the global Moran's I was low for Hispanic, but it might not be the case for when we look at other racial groups. So that would warrant doing a analysis in which we take into account geography using a geographic weighted regression, because something is going on with space. Space is something we want to take into account. As far as data goes, to utilize for the regression, I will use data from the American Community Survey and the 500 Cities Project. And the variables of interest, the established risk factors I went over previously, healthcare-related factors would be lack of health insurance, density of medical oncologists, and PCPs. MSSA's related factors would be the urbanicity of the MSSA, disadvantage and affluence score. Additional factors include physical inactivity, high blood pressure, marital status, and country of birth. And this might require me to do a principal components analysis because there are quite a few variables here, and I think the model would be overly full. And then I also didn't include a slide for my future goals, so I'll just tell them. I want to improve my cancer epi and causal inference methods. I want to, for my dissertation work, learn more about how the microbiome plays a role in cancer. That's what I'm very passionate about. I want to learn more about different cancer data sets because I found it to be a rate limiting step when you are trying to design a study, because if you don't know where to get the data from, it's really hard to kind of move forward. And then I want to learn about fellowships that are both predoctoral and postdoctoral. Here, I just wanted to show you an example of the data, which is really cool, and I just wanted to make sure everyone knew about it. So this is the 500 cities data, and it's so easy to use. You can just type in they covered, essentially the data set covers 500 cities at random throughout the US. This one, I used Chico, California, because it was in one of the hotspots that we identified. And the variable we're looking at is the 2015 binge drinking among adults aged greater to or equal to 18 years. So you can have these cool maps that are super easy to use and show other people. I think they're using ArcGIS fundamentally underneath anyways. And then you have these prevalence estimates by census tract. So census tracts are smaller than MSSA, so what I can do is just aggregate it up to MSSA level in my model. So the strengths of the study: it was a comprehensive population-based registry of incident cancer cases in California. There were multiple sources of contextual data to understand the socioeconomic, geographic, and spatial, and other characteristics that contribute to disparities in liver cancer incidence. The limitations: there's the sensitivity of directly standardized rates to small numbers of cases and small population sizes within MSSAs. There's a modifiable area unit problem, which is a classic problem when you start doing geospatial analyses. So this is essentially saying that had I done my analysis in a different unit instead of MSSA, for example, a county or census tract, maybe my results would look completely different. There's an inability to assess temporality and make individual level conclusions due to the cross-sectional design of the study. So obviously at any point when you use aggregate data, there's potential for ecological fallacy. The study is descriptive in nature and requires further exploration to assess causality. So if we do find something interesting, we would need to do individual level modeling, and we would want to use a directed acyclic graph just to identify the true confounders versus the colliders, so we don't include unnecessary variables. And additional analyses are to be conducted on this preliminary work. And these are my mentors. So Dr. Thompson was my primary mentor, and then I got some help from the geography department, which was really cool. I think that's it.
One of the advantages of inviting old people like me to this is you can relate to some history, you know, like the Arabs came to build cars and stuff like that. Hotspots for breast cancer were noted some time ago in both Long Island and San Francisco, and the NCI spent an enormous amount of money because everyone assumed there was either something in the water or something that accounted for this. And it turned out that when you looked at the known risk factors, they just clustered in those places. So in the case of breast cancer, it was women who had delayed having children or were nulliparous. There were age, income, you know, the different things that just made Long Island a hot spot for breast cancer, even though there was nothing about Long Island that you know, could be apart from these known risk factors. And I think you're probably likely to find something like that in your hot spots or cold spots for liver cancer, where intravenous drug use, where you have more hepatitis B and C, which is probably not in any database anywhere, but might come up, you know, that would account for these things as opposed to something in the water.
Right.
How are you going to try and figure out what causes your hot spots or cold spots?
What I was planning to do was run the regression models within the hotspots, and then I was going to try and compare the magnitude of, so the thing with GWR, the way it incorporates space into the regression analysis is that it allows the parameter estimates of the model to vary by each MSSA or whatever spatial feature you choose to assess. So then what you can do is you can compare the parameter estimates themselves across different hotspots. So that's one thing you can do. And obviously this is very descriptive in nature in a whole, so I would definitely suggest to continue on and do like an individual analysis to actually move towards causality and not just a descriptive study in nature.
Because obviously there are places where the hot spot is related to the geography. You know, cave dwellers in China who are exposed to radon, you know, things like that. So I mean, it really is quite complicated, as you'll probably find out the hard way. But given that in the case of liver cancer, a lot of the risk factors are pretty well defined. The question is whether or not you have the databases that will allow you to probe those known risk factors, like, hepatitis B prevalence, hepatitis C prevalence, binge drinking you mentioned, et cetera.
I think that's the tricky part for sure, is finding all of the data for all of the covariates at the level at which we need to have a fully appropriate model.